My name is Ritu Banerjee. I'm a pediatric infectious disease physician at Vanderbilt University in Nashville, Tennessee, the United States. So we did the FAST trial because we wanted to know if use of a test that more quickly tells you what kind of bacteria is causing a patient's sepsis would actually improve outcomes for patients. And importantly, we did this trial in countries with high antibiotic resistance rates because we felt that these kinds of rapid blood culture tests were more likely to benefit patients with resistant infections. Overall, we found that use of a rapid test compared to conventional blood culture testing did not improve overall clinical outcomes for patients like mortality, length of stay, transfer to the intensive care unit, or relapse of their infection. But we did find that patients who had rapid blood culture testing had more rapid targeted antibiotic treatment, meaning they got on more appropriate antibiotic therapy faster. We also found that there might have been a slight reduction in length of hospitalization in patients who had the most resistant bacterial infections. So the positive findings in the FAST trial were in a couple of patient subgroups. So in those that had cephalosporin-resistant bloodstream infections, there was a trend towards hospitalization that was 3 days shorter than patients that were in the control group. In those patients that had the most resistant forms of bloodstream infection, carbapenem-resistant gram-negative infections, the proportion that remained in the hospital at 30 days was much lower in the arm that had rapid testing compared to the arm that had control testing. And then in all randomized patients, the time to getting on effective antibiotic therapy was faster in those that had rapid testing compared to conventional testing. The other important finding that was different between the arms is that those that had rapid testing had a greater number of antibiotic stewardship recommendations and greater compliance among the clinical teams with the antibiotic stewardship recommendations. We hypothesize that use of the rapid test led to greater compliance with stewardship recommendations because clinicians are often a little bit reluctant to change their antibiotic treatment without confirmatory testing from the microbiology laboratory tests. So if you could get them blood culture results from the microlab faster, they're more likely to trust the stewardship recommendations to escalate or de-escalate antibiotics. And therefore, we think that's why compliance was a little bit higher in the arm that had rapid testing compared to conventional testing. I think that use of an unfamiliar test also made clinicians probably a little more reliant or trusting of the stewardship team compared to use of conventional tests that they're very comfortable interpreting and using. We don't know that. We can't say that definitively, but that's a hypothesis. Whenever we roll out a new test that clinicians are not familiar with, I think there's reluctance to immediately trust an unfamiliar test. So it could be good to have the stewardship team alongside them, kind of helping to interpret the test and test performance, assure them that they could trust the results and act on the results. Lack of access to first-line, newer, effective antibiotics to treat resistant infections is a big problem, especially in low resource settings. This is known as the treatment gap, and unfortunately, the reality is that countries that have the highest rates of antimicrobial resistance often have the least access to these more expensive, newer, and more effective therapies that are often recommended in our guidelines. So unfortunately, we did have several sites in our study where they did not have access to the most effective therapies, even though they could detect presence of resistant bacteria more quickly. And of course, this probably led to reducing the impact of the rapid diagnostic, because even though you could detect the bacteria more quickly with use of the rapid diagnostic, if you didn't have access to therapies, you couldn't improve outcomes for your patients. We saw some benefits in the subgroups of patients with resistant infections. And so we think that the subgroup with cephalosporin or carbapenem resistant infections probably are likely to have the most benefit from rapid tests. but an entire cascade of care is required, right? You don't need just a diagnostic, but you need the therapeutic. You need, access to these diagnostic tests. Ideally, you should have a stewardship team that can help communicate the results from the microbiology laboratory and help translate them into appropriate actions by the clinical teams. So it's difficult, for clinicians to always predict which of their patients are going to have a resistant infection, but there are certain risk factors that predispose to antibiotic resistance, like immunocompromised hosts or patients who are in the ICU or have prolonged hospitalizations or have a lot of healthcare exposure. So it's possible that clinicians could denote that this is a patient in whom they're suspecting a highly resistant antibiotic, a highly resistant bacterial infection. And they could then communicate that to the laboratory, and then the laboratory could then do rapid testing on those subgroups of patients in whom the rapid diagnostic is likely to have the greatest impact. So the FAST trial raised a lot of additional questions that we'd like to study in future studies. So one question is there a threshold of resistance prevalence above which use of rapid tests become cost neutral or cost effective? So we're doing a cost effectiveness analysis, and we're going to model different resistance rates and try to get at that question. Another question is, what is the price point for rapid diagnostics at which their use would become cost effective? I think that's a really practical question that a lot of hospitals, think about before they routinely implement a new test. And then another question is, how fast is fast enough? We used a rapid test that provided results, in 7 to 8 hours from a blood culture turning positive. But maybe that's not fast enough. Maybe we need rapid tests that give us a result within a few hours of a patient presenting with their sepsis syndrome. And then, another question is, what are the best implementation strategies? Right now, in the FAST trial and in hospitals throughout the world, when there are stewardship programs that help translate results from the microbiology laboratory to clinicians, they operate in different ways. So are there certain implementation strategies that are more effective than others? So there's lots of questions and lots of work to be done in the future. I think a take-home message from the FAST trial is that although we didn't see, tremendous benefits in terms of hard clinical outcomes like mortality or relapse of infection, we did see improvement in the quality of care we can provide for patients, meaning we could get patients on more effective therapy faster. We could escalate therapy if they were on ineffective therapy. We could de-escalate therapy if they were getting over treatment for their infection. And all of these are really hard to quantify the benefits, but there are benefits at the population level to using narrower spectrum antibiotics more quickly. And I think that overall quality of care can be improved with use of these kinds of rapid technologies. And that maybe it's aspirational to expect a rapid blood culture diagnostic to save lives, but maybe the outcome we should be assessing is a process measure than mortality benefit.